Abi-009 in surgically refractory epilepsy. Dr. Hauptman is the Associate Professor in Neurologic Surgery at the University of Washington, Seattle Children's Hospital.
Okay, so thanks for having me. We're going to switch gears a little bit because I'm a surgeon, and so forgive me because I'm a surgeon. Let's see if I can get this right. All right, terrific. So I've dedicated my entire professional career to date to taking care of children with refractory epilepsy, as many people in this room have too. About 10 years ago, when I decided this was going to be my life's calling, I really coned down and focused not only on what we could do, but what we couldn't do. And it became very apparent that epilepsy surgery in children, under some circumstances, works fantastically. Hemispheric disconnection for hemimegalencephaly or Rasmussen's encephalitis, Sturge-Weber, 90+% are angle 1. Cortical dysplasia gets a little trickier. Cortical dysplasia type 2, they generally do quite well because we can identify the lesion and take it out. Cortical dysplasia type 1, of which really cortical dysplasia is the most common entity that we encounter in pediatric epilepsy surgery, is really tricky. And the seizure control rates are much lower. And so I became obsessed with this protein here, mTOR, and I ended up getting a PhD in doing cellular electrophysiology. And what I learned is that the key might be here. About a decade ago, people started publishing like gangbusters about mTOR. Mammalian target of rapamycin is a serine threonine kinase. It's in every single cell in the body. It seems to be kind of into everything. It's into aging. It's into all kinds of progressive neurodegenerative diseases. And it's in epilepsy. And there are both in vivo and vitro models that are really convincing that mTOR might be the key here. Around that same time, our group up in Seattle Children's started sequencing resected brain tissue at the time of epilepsy operations, and we found really high incidences of disruptions in this PI3K, AKT, PTEN, mTOR pathway. And interestingly, as we're getting better at sequencing, we're finding more and more aberrations. And so we're probably up to about half of all samples being resected at the time of surgery are showing aberrations in this pathway. A lot of this is cortical dysplasia, but a lot of it is not. So we decided, I totally switched gears. I went from this like PhD basic scientist, cellular neurophysiologist. I was challenged by one of my colleagues, Jeff Ogen, and he's like, dude, bring this to the bedside. And I'm like, what? It's like totally foreign to me. So I was able to find a company that makes an albumin-bound rapamycin called Abi-009. And they allowed me to construct the trial and give me a drug. And so we took kids who, these are the hardest kids to take care of. They failed epilepsy surgery. They're at the end of their road. They go on to get VNS or RNS or anything that's not curative. So all of a sudden you have these kids who are surgical failures who are unfortunately destined to a high SUDEP risk because they continue to seize. And SUDEP and developmental decline are the key barometers that we look at in pediatric epilepsy as far as outcome are concerned. And so I took these kids, we kept them on their home ASMs for a month. We put them on drug for a month because that's what the FDA let us do. And then we washed them out for 3 months. And I'm going to show you some very raw, unvarnished data, but I think it's pretty cool. I hope you do too. So this has taken about 2.5 years. We have a 3+3 dose finding design because no one's ever really done this before outside of tuberous sclerosis. So we didn't even know where to start. So we took 3 different dosages, 5, 10, and 20 milligrams per meter squared. We enrolled kids. And I actually have a subset of kids that have tuberous sclerosis I'm not gonna really talk about today. These are kids that don't have tuberous sclerosis, cortical dysplasia, and we put them on an mTOR inhibitor. From a safety perspective, which is really what we were looking at here as our primary outcomes, it's safe. There were no dose-limiting toxicities. I was able to get all the way up to the 20 milligrams per meter squared, which is a really high dose. I was getting serum trough levels like in the 50s in these kids, which is very high. I mean, take the EXIST trials, for those of you who know the TS literature, the high serum trough level in the EXIST trial was like 9 to 15. And so this is incredibly well tolerated. Stomatitis, mucositis were very minor, which is what we saw in the EXIST trials too. And the FDA asked us to look at suicidality. The risk wasn't increased. What we found is that there was a group that clearly responded and a group that didn't. And the group that responded, which were the three that I'm showing you on the left-hand side of the screen, P01, P04, P06. P06 is cool because I have her genetic sequencing. She has an AKT3 mutation. And for those of you who are familiar with the pathway, AKT is upstream of mTOR. So it makes sense. The other two I don't have their sequencing on. All three of them were seizing at incredibly high rates pre-drug, post-surgical failure. They responded well on drug and then they washed out. And P06, who has an AKT3 mutation that otherwise would have never been detected outside of her brain surgery, because she's a mosaic and it's only her brain tissue. So these kids are really, really challenging to sequence. She went from about having 100 seizures a day to being seizure-free on drug. And because of that, I have her on OLE, which I'll show you in a second. But the responders, their seizure counts went down, their percentage of seizure-free days went up. They had a reduction in their average weekly seizure frequency, increased percentage of seizure-free days. And then the FDA let me put them on OLE. And I have these kids on drug now for over 2 years. And P06, who is, let me give you some background. P06, she got a hemisterectomy because we thought she had catastrophic hemispheric epilepsy. And she failed her hemisterectomy. And she didn't fail it because it was a technical failure. She was seizing from the other side. Why? Because she had an AKT3 mutation. And for those of you familiar with the pediatric epilepsy literature, there is a failure rate to hemisterectomy, and it's between 10 and 20%. And it's not technical. It's because these kids have genetic etiologies that we don't know. And so we can't sequence the good side, we can sequence the bad side, and that's what we're gonna figure this out. Anyway, she was having about 100 seizures a day, pre-drug. She has been seizure-free for 2 years. I mean, not a subtle outcome. The other two have also had persistent, sustained reductions in their seizure frequency. And like I said, I have close to 2 years worth of data on them now. And so in the end, sorry if I'm over time, I hope I'm not. In the end, it seems to be safe. It seems to be well tolerated. Certainly a subset of kids that benefit from this. We went into this just trying to recruit kids, which meant that we didn't want to make sequencing a barrier to being admitted to the study. But clearly that's going to play a role here, in the future. But where I sort of petition everyone in the room who has resources that are way more vast than mine is this idea that we need to pivot and this comes from a surgeon, so take it with a grain of salt. We need to pivot this idea of traditional anti-seizure medications, working on neuronal physiology. The neuronal physiology is an epiphenomenon. The fundamental issue is the genetics. And so we really need to pivot towards biologics. And so that's why I want to petition you guys to think about. I know you already are thinking about it. But I really want you to think about it because that's, I think, the future of ASMs. Anyway, thank you.
Questions from the audience? Somebody's running up to the mic.
Hi there. My name is Alex Munt. I'm an investor, so if anyone else has a real question, then you should take it. But for the EXIST study that the person next to you is one of the primary investigators for, the exposures that everolimus was able to achieve that 9 to 12 and 12 to 15. I'm curious for the rates of stomatitis that you saw in this study, because based on that study, I would have expected them to be kind of off the charts.
Yeah, they're not. And I can't explain to you why. But the 3 kids that I had that had severe stomatitis were all at the 20 mg per meter squared dose, which is an incredibly high dose. And remember, the PK and the PD of this drug is completely different than everolimus. It's intravenous once a week, so it spikes on day 1 and then tapers to day 7. There probably is some dose-dependent effect, but what's fascinating is that none of them were that severe. What I'm also not showing you, which I think is really cool, I have Dr. French here, what's really cool is that my TS kids are all seizure-free on this drug.
Yeah, I mean, that's amazing.
Yeah.
Can you speak a bit more to the TSC experience and kind of
Yeah.
for people in this room, what they may be thinking about, whether using everolimus or putting patients on a trial on this?
Yeah, so I mean, I think, and there are people here better qualified to answer this than me, but the heterogeneity in the TS community is significant, right? There's not only just TSC1 and TSC2, but there's mosaics. There's all kinds of differences in genotype phenotype that we don't totally even understand. And the other challenge is that so mTOR makes two complexes at the end. There's a complex 1 and complex 2. We all know a lot, or we think we do, about complex 1. We really don't know that much about complex 2. And then they have a weird, not weird, but they have a complex interdependency between the two levels. And what's interesting is a lot of rapamycin studies at low, and this is why I think it works so well in TS, and of course it's based on 3 patients. In low levels of exposure to rapamycin crushes mTORC1, but not mTORC2. But in high doses, rapamycin in vitro crushes mTORC1 and mTORC2. And it makes you wonder if that has a relationship back upstream to AKT and PI3K. And so, again, I figure need more numbers, more patients, and we're certainly going to look at this. But I think the reason why this is so effective is that we're getting very, very high levels, probably in